So we are good to go.
Good evening to everyone. I'm Dr. Omkar Swami on behalf of Emcure Pharmaceuticals Limited. Welcome you all in this next session of No Thrombosis workshop in acute ischemic stroke. Every month we gather together and discuss two interesting case studies and a lot of discussion. So to take this session forward, it's my pride privilege to welcome Professor Dr. Subhash Kaul sir. As we all know, sir is a course director for this No Thrombosis series. Sir is a senior consultant and stroke specialist at KIMS Secunderabad and chairman of KIMS Foundation and Research Center. Sir has been a faculty in a Nizam's Institute of Medical Science for almost 3 decades and a former professor and head of the Department of Neurology and a dean at NIMS Hyderabad. Sir had thousands of publications on his credit and has been worked as a principal and co-investigator for several national and international projects, including large single center Hyderabad Stroke Registry founded by ICMR. Sir has a recipient of a state teacher award by Telangana government in 2017 and has been a past president of AP Neurologist Association, past president of Indian Stroke Association, and past president of Indian Academy of Neurology. Welcome you, sir. I now welcome our course moderator, Dr. K. Asokan, sir. Sir has been with us for last few months, and we have incepted this program in discussion with Dr. Ashokan, sir. Thank you very much, sir, being a part of this program. And your keen interest is making this program a great success. Sir is senior consultant neurologist at Sri Ramakrishna Multi-Speciality Hospital in Coimbatore. Sir has been a president of Coimbatore Neurology Society and president of Tamil Nadu and Pondicherry Association of Neurologists. Sir has been a regular speaker in a national and international conference on a stroke and epilepsy, and a part of a various international clinical trials in his department. And sir has a keen interest in a stroke therapy, and that's why sir very meticulously join in the every program of No Thrombosis every month and bring a lot of discussion. Thank you so much, sir. Now I welcome our moderator, Dr. S. Meenakshi Sundaram, sir. Sir is senior consultant neurologist at Apollo Hospital, Madurai. More than 2 decades of experience in clinical neurology and been a recipient of the prestigious and presented many papers in national and international forum, and a recipient of the prestigious Best Research Paper Award at 10th Annual Conference of Indian Academy of Neurology in 2002. Sir has also been a principal investigator for many clinical trials of refractory partial epilepsy, stroke, acute stroke interventions. And sir has been an editor for South Asian edition of book on practical neurology by Jose Biller, published by Walter Kluwer in 2020, and contributed to the many chapters in the books on neurology. Thank you very much, sir, being a part of this program. Today, we have a special guest. So I welcome Dr. Shripad Pujari, sir. Sir would be a guest moderator for today's session. Sir is a consultant neurologist at 2 prestigious institutes in Pune, Dinanath Mangeshkar Hospital and Noble Hospital. Sir is working as a clinical and research neurologist, worked in a clinical and research neurologist at King's College Hospital, London. Sir has been involved in a basic science research on cytokines in inflammatory diseases of nervous systems, including multiple sclerosis. Sir is, as I mentioned, is working in 2 prestigious institutes of Dinanath Mangeshkar and Noble Hospital in Pune, and also working, he's a private OPD at Mukund Nagar in Pune. Sir has a special interest in multiple sclerosis, NMO, inflammatory disorders, COVID neurology, and sir had many publications on his credit. Thank you very much, sir, joining for this session, and we hope you will enjoy this session thoroughly. Today we have 2 case presentations. I welcome our expert speaker, Dr. Aniruddha Rao Deshmukh. He will be presenting a unique case of a stroke. Sir is working as a consultant neurologist at Ozone Hospital, Hyderabad. Sir has many publications on his credit. So we welcome you, sir. Now, our second expert speaker would be Dr. Surendra Yadav Osha. Sir will be presenting thrombolysis in minor stroke. He's working as a consultant neurologist at Eternal Hospital in Jaipur, and a member of he's a member of many international societies, and including Epilepsy, Parkinson's, and Movement Disorder Society. We welcome you, sir. So with this short introduction, I will stop my presentation, and we would like to hand over these sessions to our moderator, Dr. K. Ashokan sir, Dr. Meenakshi Sundaram sir, and Dr. Shripad Pujari sir, to open the session till our post director joins, and then we can start with the first presentation. Over to you, sir.
Yes, sir. Thank you, sir. Thank you very much for your kind introduction of all the post director and moderators. Yes, as you told, this we have been doing this program for the past few months successfully, very successfully, with very good attendance, and case presented of high interest, and we had very good discussion, and we learned a lot. To be very frank, I learned many things by attending these programs. Without wasting much of our time, I'll call the first speaker to go on with his first case.
Dr. Aniruddha, would you like to share your slides? Go ahead.
Yeah, I'm doing. Yeah. Is it visible? Your screen.
Yes.
Yes. Okay. Good evening, everyone. Respected teachers. I'm presenting the first case. I was supposed to be a second case, but I'm presenting first now. So we had a patient, Abdul Aziz, 49-year-old male, presented to the ER at around 1:30 a.m. The approximate time of onset of symptoms was around 12 a.m., where his wife noticed that there was some slurring of speech and deviation of mouth towards the right side. And then he was a little drowsy. And by the time the next half an hour, they noticed that his left side of the body, especially left arm, there was positive movements. So they came to the hospital around 1:30 a.m. within 1.5 hours. The patient was a known case of hypertension. He's a known case of non-valvular atrial fibrillation and was on dabigatran 150 BD. But because of Ramzan and fasting, he had discontinued his tablets for the past 2 days. He was a chronic smoker and known case of COPD. On examination in the ER, the pulse rate was 145. He was in atrial fibrillation. BP was 180/100 and SpO2 was 92 on room air. He also had OSA, so most probably the supine position was causing a lot of hypoxemia. His NIHS was 11. He was drowsy, but he was able to answer some questions. There was mild gaze paresis. There was a well set in facial palsy, higher motor neuron facial palsy. Left arm was weak, left leg was also weak, and there was severe dysarthria. So total score was 11. So because of the patient was a known case of atrial fibrillation on dabigatran, we had to wait for the investigations. We sent for CBC, PTNR, and RFT. Platelet count was 1.7 lakhs. PTNR was 1.3. The PT was slightly raised. It was 17, but still we went through. APTT was 36 and the RBS was 131. This was a CT brain done around 15 minutes after arrival to the ER. CT brain looked almost normal except the mild suspicious hypodensities on the right side in this M4 and M6, M5 and M6 areas. Apart from that, there was no major hypodensity or any bleed. CT angiogram was done to rule out any large vessel occlusion, and these you could see the right MC and left MCA, they're all fully patent. So thrombolysis was planned. The weight of the patient was 109 kgs. So dose going to 0.25 milligram per kg came to 27 milligrams. Time of thrombolysis was around 2:30 a.m. So time of thrombolysis was 2 hours 30 minutes, around 12 to 2:30. At the time of thrombolysis, BP was 160/100. Pulse rate was still 150, and he was in atrial fibrillation. The NIHS score was still 11, and MRS was 4. The delaying factors in these patients was one was that we had to wait for the PTNR because of the dabigatran he was taking. Relatives took some time to decide whether they want to go after explaining all the risk factors of bleeding. And there was slight misinterpretation of window period, where when we told them around 3 to 4.5 hours is a good window period, they thought they could wait till 4.5 hours. So we had to explain to them that that's not how it works, and earlier we do, better it is. So that took a little time. So there around 20 minutes were wasted. Post thrombolysis after 1 hour, NHS was still 11, pulse rate was 150, atrial fibrillation, and BP was 160 by 100. This was a CT scan done after 4 hours of thrombolysis. There was a small bleed in the left caudate nucleus, but there was no dip in the sensorium, in patient sensorium, or there was no increase in weakness or any right side facial palsy or hemiparesis. This was the MRI done next day morning around 11 a.m. It showed a infarct in the right MCA territory around the central, near central circus with a diffusion restriction. This was the SWI image of the in the MRI, which showed that left caudate bleed, which was not there in the before thrombolysis. This is the MRI angio, as we saw in CT angio. Both the MCAs were and ACA were patent. On discharge, patient was discharged after 5 days. Because of his OSA, COPD, and hypertension, there was it took some 2 to 3 days for the patient to come out of the drowsiness and to start walking. So on discharge, the patient's NIHS was 4. There was mild facial palsy was there, mild dysarthria, but patient only had a mild left arm drift, pointer drift. He was able to use the left arm and he was able to walk without support and go to the bathroom without support. So the NIHS at the on discharge was 4 and MRS was 2. Patient was discharged on dabigatran 110 milligram BD. And this was on 1 week back. Patient just came for a follow-up after a week, yesterday itself. And patient was quite okay. He was able to walk. There was no facial palsy. The left arm drift was still there. Dysarthria had improved. MRS was, I think, 0. And the repeat CT scan showed there was no increase in the bleeds, new bleed. Thank you.
Thank you, Dr. Anirudh. My co-moderators, Dr. Meenakshi, Dr. Pujari, would you like to comment on this?
Yes, I think
Dr. Kaul sir has also joined. Welcome,
yes,
sir.
Welcome, Dr. Kaul.
Good evening, Dr. Kaul, sir.
Sir, namaste, sir.
The way I would look at the case was because the patient had anyway skipped.
Yeah. Hello. Hi.
Hello?
Namaste. Please, you.
Can I comment, sir? Namaste, sir.
Yes.
Namaste. Meenakshi, how are you?
Sir, namaste. How are you, sir?
All well.
Good evening, sir.
All fine.
Good evening. Please carry on.
Yes.
So, Meenakshi, please give your comments. And...
Yes.
I think, sir, Pujari sir was
Dr.
speaking.
Anirudh, the case just picking up for that. The summary of that was a gentleman who presented with the stroke with the NIHS stroke scale of around 11. And this gentleman was on dabigatran, which he skipped because of Ramzan fasting, came with a stroke, and there was an infarct. And the patient underwent stroke thrombolysis with tenecteplase, and the patient did well with the NIH stroke of 4 at discharge and doing very well as the latest day prior to this, today's presentation. Nice case, sir. Thank you, Dr. Anirudh. Now, the question which I would like to tell you is that now, even if the patient had been on dabigatran, now there are now good data to show that the patients could still be thrombolized. The recent paper was in 2020, and it was in stroke, where there are more than 50 patients. I think around 53 patients who were on were given idarucizumab and taken up for thrombolysis, and they did well. In fact, the hype of extra thrombosis which could happen because we are administering idarucizumab was not there in the study. The thrombotic rates were not higher, and second, the hype of looking at a lot of hemorrhages because the patient had received dabigatran was also not seen. The rate of hemorrhage was only 3.8% compared to non-idarucizumab patients were 3.9%. So comparable rates of hemorrhage, whether they were on dabigatran or not, because they had been given idarucizumab and then thrombolized. Probably with that in mind, in today's scenario, because idosumab is quite freely available, given that the stroke was quite a large one, NIH stroke scale 11 leaves somebody with a good deficit. We could have even thrombolized, even this person I would have done that. The case did very well, and your MR subsequently post thrombolysis also looks fairly okay. And that's a great success, really. Congratulations, sir.
Was this patient given idrucizumab?
No, sir.
He had stopped for 48 hours, sir. So
Okay.
you just check the coagulation profile and.
Okay, yeah, because if it was 48 hours, then there was no problem at all.
Yes, sir.
Then you don't have to even worry about anything, not even about coagulation profile, if it's more than 48 hours.
Yes.
Absolutely.
If it is less than 48 hours, then all these things you need to do.
Okay, sir.
Yeah, I think that is a great thing. But why had he missed for 48 hours? Did you go into that?
Yes, sir. It was Ramzan period and they were fasting. So, and he is anyway, sir, not a very good patient. I mean, he was not taking any of his medicines on time. He is a chronic smoker and
so for once his negligence helped him, right?
Yes, sir. Yes, sir.
Okay, good.
Although we must say that he developed the stroke because he skipped the Begetran.
Yeah,
that's
probably
also
was the reason for his this thing.
That's
And the
also
bleed was asymptomatic, although
Yes,
it was at a site different from the site of ischemic stroke.
yeah.
At the age of 49 years, I think it's a. Do you think, Dr. Kaul and Meenakshi, it's a matter of concern that the bleed was at a site away from the site of ischemic stroke? Does that mean that he has vessel disease which has occurred early? Because he bled in the left caudate, although it was asymptomatic.
Yes, sir. Yes, sir. I too agree with you and Dr. Ashokan. Thing is, and it showed some microbleeds also.
Absolutely.
Along with the little larger bleed, I had microbleeds also. It should be a form of a small vessel disease. And as I said, now the dominant hemisphere is left only. Still, it's not right, left dominant hemisphere. But the patient presented with left hemiparesis and maybe dysarthria. But still, speech difficulty, I think should be, even if it's a minor disability, we have to thrombolize it. Because what you think minor, even if it is improving later neurologically, but things like hemianopia and aphasia or dysarthria, I think should be taken up for thrombolysis. But here, this bleeding has occurred not due to thrombolysis. That's what I feel. It's part of the small vessel disease, and along with it, there are microbleeds also, and
Yes, yeah.
luckily there was no any large vessel occlusion.
No, but was the bleeding after the thrombolysis? After
Yes,
thrombolysis?
Yes,
Yeah,
sir.
Yes,
Yes, sir. The first CT did not show any bleed, sir. The second, the post-thrombolysis CT showed that left caudate.
No, but you see, the question is that thrombolysis, obviously, because it has happened after thrombolysis, so there is some connection. And this may not be causing any problem to the patient, but post-thrombolysis bleeding can happen into the infarct. It can happen away from the infarct, and it can happen anywhere in the body. So,
yes.
but fortunately, there has been it's not going to cause any.
Not change the NIHS.
Yeah. So that is good. That's it. Yeah.
Sir, I have one query in this patient. Actually, because he was having atrial fibrillation and pre-thrombolysis, post-thrombolysis, his heart rate was not controlled.
Yeah.
So with the fear of having a reinfarct, I continued giving him heparin after 24 hours of thrombolysis, even though there was a small bleed in the left caudate.
Yeah.
So in such patients, is it advisable? The risk-benefit ratio, should we continue giving heparin or dabigatran in such patients who have small bleed?
Dabigatran is out of question.
Low molecular weight heparin or unfractionated heparin?
I'm low molecular weight, sir. We gave low molecular
Low molecular weight. I think it's a very difficult issue here because he's already had a fresh bleed, and if we go by any criteria for antithrombotic, heparin and anticoagulation, then we are advised actually to wait. But on the other side, you are very right that he's already thrown an embolus because he skipped his dabigatran, and you are worried that he shouldn't have another embolic episode. So all in all, if I were in your place, I would have talked to the family, discussed the pros and cons. And the only thing is the caudate bleed was not large and it was not symptomatic. And the period of 10 hectoplasm is, half-life and washout period is small. So all in all, I would have discussed the family, and if the family were inclined to take that small risk of heparinization, I would have done it.
Okay. So in
No,
this
I would
case, we
like to
did,
make
sir.
one
Luckily,
comment.
nothing
I would
more.
like to make one comment on that. You see, this has been a perennial discussion always.
Yes.
What to do after acute cardioembolic stroke, and there have been many studies on that.
Yes.
And what the studies have showed is that after a ischemic infarct due to embolization from atrial fibrillation, if you go to next 1 month after that, this is the data from the studies, from the trials,
Yes.
not our intuitive. They have shown that if you give heparin to them, the chances of bleed are much more than the chances of re-embolization. Re-embolization can also happen. Your fear is genuine. But if you give heparin, the chances of bleed are more than the chance of embolization, re-embolization. Therefore, generally they say that don't give them full-fledged, full-throttled anticoagulation after cardioembolic stroke, at least for 2 weeks, at least. So I think the middle course which you can take is that you can give a, once a day heparin in these cases. Because if you give twice a day heparin, that may put you at a risk of bleed. But once a day anticoagulation is okay, but not dabigatran, definitely. That will cause bleed. Yeah. And after 2 weeks, it's okay. Then you can treat them like anybody else. Yes.
So when would we start dabigatran? When would
after 2 weeks. After
2 weeks.
Yeah.
Okay.
Yeah.
Okay.
The doubt, sir.
Sir,
One doubt, sir.
Yes, sir.
Sir, here, in case we need to give anticoagulation also back, I would think that it is preferable to give unfractionated heparin, because even if the bleed increases, I would have the confidence of giving protamine to this patient rather than giving LMW heparin where reversal could be difficult. So also dabigatran where reversal could be expensive. So that's what I've gone with it, sir. And one more doubt in this case comment is that I'm quite surprised that you have to teach us why this is happening. That this patient, if at all, skipped anticoagulation only for 48 hours. A non-valvular atrial fibrillation patient skipping medication only for 48 hours. Why did he develop such a stroke? Where did this embolus form and come from? This is a question which is intriguing me in this.
It's too short. I agree, Dr. Meenakshi Sundaram. For a new thrombus to form within 48 hours of skipping anticoagulation. And he's a young patient as well. He's less than 50. So
Yes, 49.
say, Dr. Meenakshi, that we need to look for alternative sources of thrombus. Is that what you mean?
Yeah, I do not know. How did it really happen? One guess which I said was answered by the speaker. He said that this may not be the first time he had missed his medication. So that could throw some light into it. That could be possible. Or there is some other mechanism which is possible. Probably we are sitting with an atrial cardiomyopathy already in the background. And this guy is a high-risk patient for developing stroke. Probably he should have been underlying atrial cardiomyopathy. That could have been my guess in this patient. Not just AF alone. And we take all sir's comments on that. Yeah.
One more point I would like to make is he was on 110 milligram twice a day.
150, sir. When he
He was on 150. Okay.
Yes, before. Yes, sir.
But fine. Then that point doesn't.
Sir, if we have time, sir, I have one doubt about some other patient. Actually, we had 1 month back, we had a young patient, 32 years old male, who had a massive chest MI, and he came with left hemiparesis. He in the emergency, when we saw, there was a big MCA infarct on the left side, but less than 1/3. We thrombolized him and we shifted him to the ICU. There was not much improvement, but overnight he developed seizures and he was intubated, and we repeated CT in the next morning. There was a massive right MCA infarct. And because opposite side, right MCA infarct. So in the ER previous night when the echo was done, they couldn't see anything because of the heart rate was very high. But later when the cardiologist did, there was a big clot in the LV. LV clot was there because of the MI. So in such situations where there is, once you thrombolize, you cannot again thrombolize, and you cannot even heparinize the patient in such situation. So acute MI plus stroke, if we are suspecting there is some LV clot, is it better to start give anticoagulation rather than thrombolize and then risk him for another infarct.
That's the whole thing. So he already threw in another. See, two things. One is that because of two reasons. One is that he probably had a large anterior MI and he was susceptible, although the first echo had not shown, he was highly susceptible to form an LV clot. And the second point is that the initial left MCA also is a large infarct. Maybe if we had considered mechanical thrombectomy rather than IV lysis at that moment, we may have, I'm not saying certainly, but we may have prevented the LV clot from dislodging and occurrence of the second embolic event. And second, is it possible now you had IV thrombolized, you developed an stroke on the other side ischemic? Is it possible we could have done a mechanical thrombectomy for the second event if the disability was severe?
Yeah, sir. So for second event, we consulted the radiologist and they said it was a large occlusion and the GC was very poor. So they went for hemicranotomy instead of thrombectomy.
Okay, got it.
Probably your second.
Again, Dr. Kaul.
Yeah, please.
Two consecutive events, as we are seeing here. You earlier said that we wait. However, we are already in peril here. So, in a situation as this, again, we will wait for say 8 to 14 days.
Yeah, obviously, because you have got a big infarct there, no?
Yes, now I agree. Now that's another point that we already have a very large infarct. So by the size of infarct, we have to wait at least for 8-10 days.
Yeah, this is always a risk-benefit ratio we have to see. Always risk-benefit. We go for a benefit, but we have to balance it against the risk. Once you have got a, if there was not a, if the infarct size was not big, then in this situation, I would have even, and particularly if you see a clot, that's a very high risk clot situation. Then that 2 weeks can become even 1 week also, even 3 days also.
Maybe if it was medium, then we could have started in 5 days or so.
Yeah. But once there's a big infarct and all that thing, then you have to, you cannot take that risk.
Do no harm is the first.
And the other thing is that this 48 hours, if you stop that, see, the thing is that when is a person after discontinuation of antithrombotic at the risk of stroke depends when the half-life, depends on the half-life of these things.
Exactly. Yeah.
So, if you warfarin, if you stop for 1 day, probably nothing will happen. Probably 2 days also, but from 3rd or 4th day, he's at a risk. Similarly, at aspirin also, usually after 3-4 days, there is not a risk. Classically, they will get their stroke on 6th day or so. But dabigatran half-life is, by 48 hours, there's hardly any drug in the system. So they are at risk of bleed. That's infarct, yeah. But overall, I think it's a great case. We learned so much from it and you have very quickly responded to it. This case, not the other case of which you quoted. That's a different case. But the case you presented, I think there is a lot of learning that we should never give up, and whatsoever is the situation, we should respond to it. Yeah.
Doubt, sir.
Thank you.
One last doubt, sir.
Yeah.
Sir, can I ask one doubt, sir?
Yeah. Yes, sir.
Sir, the case which was dealing with that, Dr. Aniruddh, had you seen that clot on day 1 itself, the second case which you mentioned, that you did do an echo in the emergency and did see a big thrombus there? Would you have thrombolized? What would have been an implication?
Anirudh, you are muted.
That's why I thought maybe if the clot was visible in the ER itself, I wouldn't have thrombolized, sir.
Absolutely.
What was the MRA findings on the at that time? MR angio.
No, sir. MR angio was not done at that time, sir. Later, after the second event happened, because GC was so poor, and within 6 hours of first thrombolysis, he got intubated. So this is also overnight. So we couldn't do
you see,
MR
the thing is that Meenakshi's question is very valid, but in the guidelines, it is nowhere in the guidelines that you have to look at the echo and you have to look at the thrombus. Even if there's a thrombus in the LV, it is not there is a total silence on this. it is not a contraindication because it's not even required to do a echo. So suppose if you have not done the echo, you would not know that it's a thrombus, so you're supposed to thrombolize him. But we know from our experience and all that this is a risk factor. So probably I would have tried if there's any mechanical thing, or probably I personally would have gone for intravenous because it's not a contraindication as such. Although I know it's a high risk situation. But if you take 100 patients with a clot in the heart, all of them are not going to fragment. Some 5% of them will fragment. Others are going to benefit only. So, but this is an area which needs more research and more trials to give us a clear guidelines. Yeah.
Yes.
Dr. Anirudh, probably that majority of the cases would do well with thrombolysis.
Yes.
We would not done the echo. This was discussed, sir, in one of the previous meetings. So in this case, what could have happened? Sir taught us about this in one of his presentations. Now, what could have happened is that this thrombolysis was responsible for the that could have been why the patient developed stroke on the opposite side. As I mentioned earlier, there was a paper in Neurology India about a patient who had developed myocardial infarction following thrombolysis. So these are rare situations. I think it's not the majority, and we would thrombolyze whether there is anything or not. We not even bother about doing echo. That was our previous thought also. Better not to do these fancy tests because it will only inhibit you.
No, sir, actually he came with an MI. That's why we had to do an echo. The patient had MI, so then it was like whether we should do thrombolysis for MI or stroke. What should we give? How much should we give? There was a lot of confusion.
Correct.
Because giving full dose for cardiac thrombolysis might lead to bleed in the brain. That was a lot of confusion.
Absolutely.
Difficult case.
What dose you gave? You gave a neurological dose or
yes, sir. Stroke dose, sir.
Yeah. That's right. That is the recommendation. Yeah.
Yes, sir.
Sir, can we move to the second case?
Yeah, please do.
So, Dr. Surendra, would you like to share your slides and go ahead for the second case?
Good evening, sir.
Good evening.
Right.
Now, slide visible?
Yes.
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 Good evening, sir. Today's presentation on thrombolysis in minor stroke. As all we know that the thrombolysis in minor stroke is a gray area and till date is the controversial. A 55-year-old gentleman came to internal hospital emergency around 4:30 a.m. with history of sudden onset headache, inability to speak since last 2 hours, no complaint of any limb weakness, any dizziness, vomiting, double vision or blurred vision. Known case of hypertension, CAD post PTCA on single antiplatelet. He is taking metoprolol, telmisartan, aspirin 75 mg and atorvastatin 10 mg, and no any history of drug defaulter. In personal history, he had no history of alcohol consumption or alcoholic, no past history of smoking or tobacco consumption. In examination, his BP around 160-100 mmHg, pulse 78 per minute is regular, blood sugar of 110 mg per deciliter. In CNS examination, patient conscious, following command, moving all four limbs. In examination, power in all four limbs 5/5, extraocular movement are normal, no any nystagmus, ataxia, and he had only difficulty in inability to speak in form of anarthria. He can understand, he can comprehend, he can write, he can understand everything, and he command all follow all instruction. So we labeled as a anarthria. Anarthria is considered a motor disorder. It is problem with muscles that use to produce speech. As in his history, he can understand, can comprehend, though no likely aphasia. He had intact comprehension. His writing was intact and smooth, except a few spelling mistake in long sentences. He could not verbalize object name and could not read aloud. In NIHS score, we asked 2 questions about the month and age. He answered both questions in both questions rightly by the gesture. And in form of the, we said that the blink eye or squeeze hand, then he also blink eye and squeeze hands. In language, due to the NRFA, we cannot comment about the aphasia, but as we in examinations see that he had no difficulty in comprehension, no difficulty in writing, and no difficulty in understanding, and he answered both questions in NIH score with the gesture. In investigation, his ECG was normal, X-ray was normal. As he came in midnight, in early morning around 4:30 a.m. with a stroke 2 hours, we think that it may be a backup stroke. Then we go for the MRI brain, and his MRI brain is flare sequence. There is no any acute large infarct or any hyperintensity. In diffusion, there is a fatal hyperintensity in the diffusion, where we can see the minor infarct area. So his MRI shows the infarct in the cortical subcortical in precentral gyrus. His angio, brain and neck doesn't show any large vessel occlusion. So we decide whether we thrombolize or not. But he had difficulty in speaking. So we think that if his problem remain persistent in the speech, so we go for thrombolize. So we decide to thrombolize with the tenecteplase. And after thrombolysis, day second CT was normal. After we started the dual antiplatelet and statins. On second day of admission, patient started produce single word slowly and rapidly, characterized by abnormally long vowels. Additionally, he could write long sentence normally. Next day, produce normal single word, long pauses between each word when constructing the sentence. By the sixth day of admission, during the discharge, he was saying single words and short sentences normally, and we discharged the sixth day with dual antiplatelet and steady. In review of literature, clinical outcome of the thrombolytic therapy in patient with the mild stroke, a single center experience in a tertiary care institute in Turkey, in which the 350 patients received thrombolytic therapy, out of which they said that in conclusion that the patient with the treated with the RTPA with minor stroke, then definitely demonstrate the better clinical improvement at the discharge or at the 3-1. Thrombolysis in very minor ischemic stroke. In this study, total thrombolized patient 477 patients, out of which only 12 patients were treated of very mild ischemic stroke. In out of 477 patients, in which the thrombolized of the 12 patients with the minor stroke treated with the RTPA, no complication or no ICH in very minor stroke. And in conclusion, they conclude that evidence that the IV thrombolysis may be safely performed in the very minor ischemic stroke if the patient has, like the patient in their study, most of the patient with the posterior circulation stroke with the gait ataxia. So they conclude that the thrombolysis therapy should be based on the functional disability. This is original article published in Brain and Behavior. Reperfusion therapy of for minor stroke is systemic review and meta-analysis. In this meta-analysis, study was which all patients included with the NHS score less than 5 or equal to the 5, and in this study the total 10 study included, out of which 4,330 patients were identified. Risk of ICH were higher in the RTPA group in patient of the minor stroke. There is no any significant difference in the rate of the mortality between the RTPA and non-RTPA group, and pooled rate of the good outcome at 90 days in both groups is almost same, no any significant difference. After adjusting the heterogeneity, thrombolysis was associated with the good outcome in post-hoc analysis, including only RCT. Pooled rate of good outcome and no significant difference between the two groups in the RT and non-RTPA group. In conclusion, that the thrombolysis might increase the risk of the ICH based on these available 10 study in minor stroke patient. So patient in the minor stroke patient thrombolysis result may be vary or may be beneficial at the 3 months. In this study, we can say that the patient if the patient treated with the RTPA group and non-RTPA, ICH is more in the in RTPA group, and if the patient treated, mortality rate is almost same in the both group. Thank you. So as per this case, we conclude that every patient should be assessed according as per the disability. If the patient had long-term disability like in form of the gait ataxia, in form of the isolated dysphagia, aphasia, and difficulty in speech, then patient should be thrombolized. Thank you, sir.
Yes. I agree with Dr. Kaushik that rather than making absolute NIHS, we need to gauge the degree of disability. And if the disability is significant, then we should consider lysis rather than sort of labeling minor, moderate, or things like that. So I think, and there is enough evidence for the same.
Yes, sir.
Dr. Meenakshi?
Call, sir. We'll take expert opinion from Professor Dr. Call, sir.
Yes.
I'd like to learn from him.
No,
Call, sir.
Sure. Shall I tell you something before Professor Kaul comes into this thing? Thing is, as we told already, even if it's a minor disability, the speech is a very important disability. So along with that, not only this disability, along with the MRI definitely shows there is lean infarct of the motor cortex. So such a situation, and we cannot take a chance and wait for the speech to go off. I think it's ideal to do the thrombolysis, and that's what they have done, and they got a good outcome. Again, so such an important thing. Maybe we can look for source of embolus later, but I think should be thrombolyzed as early as possible, especially in a context like this where the infarct is also there in the MRI in the motor cortex. Yes.
Is Call, sir, back, sir?
yeah. Meenakshi, see, this is our favorite topic, and we have discussed this before also, and I remember even your comments also before about this NR3 and speech and all. There is nothing as a non-disabling stroke. Everything neurological is disabling. And I remember last time you made a comment that there was some person who had some just mild sensory disturbances, and even till this day he is blaming you that you are responsible for his central pain, or So this is a very, very fascinating thing, that what is disabling, what is non-disabling. It is so subjective.
Yes.
As such, the definition of disabling is which interferes in your day-to-day life. Absolutely. But any deviation from the normal routine can be potentially disabling for that patient. So I would, if a patient has any kind of neurological deficit, I would explain to patient and thrombolize the patient. And NR3 is a very significant, you don't have to go by the scores, whether it is 2 or whether it is 4 or whether it's 5, that doesn't matter. And it should be aphasia, and it should be no. Any neurological deficit is a potential disabling symptom, and I personally would thrombolize them. But of course, I would explain to patient, and then if patient says yes, I would go ahead and thrombolize. That would be my take on this. Meenakshi, what do you say?
Perfectly, sir. We are your students, sir. We follow you.
Yeah.
Two doubts I have in that case, sir.
Because the other thing is, the other flaw which I find is, what they say is that you tell patient that, are you ready to live with this disability? Suppose a patient comes with a mild facial numbness. You tell him that, can you live with this facial numbness throughout the life? Patient may tell you, I can live with the numbness. But the thing is that it may not be just facial numbness. It can progress in next 1 hour to entire hemiplegia. So therefore, the deficit at the point at which you see him may progress. Therefore, any deficit, any neurological deficit, I would thrombolize, definitely. And I would try to convince, but I will tell the patient, find the choices of patient. And Meenakshi, last time you showed the same sentiments. In fact, this is a very, very interesting debate. In the original NIHS study, they had not included the absolutely, some syndromes they had not included only in that, which included some ataxia, isolated numbness and all. But most of the data had shown that people with mild deficits definitely improved with the deficit. And driven by that, those findings, Pooja Khatri, our own neurologist from India and US, started the PRISM trial. But unfortunately, PRISM trial could not be completed. And some of the patients had some minor bleeds and all. Therefore, it was thought to be a negative study. And they said that minor strokes should not be thrombolized. But there are faults in that study. There are limitations in that study. As of my own experience and as of surveying the maximum literature, it is safe as well as advisable to thrombolize the minor strokes. That's my take on it. Meenakshi, what do you say?
Same thing, sir, because we follow the footsteps, sir. The point is that probably in the NINS trial, most of the patients underwent only CT scan and not MRI.
Yes.
And probably isolated numbness, they couldn't really tell whether it would be stroke or not. That would make the patients non-uniform. If they come with just numbness, we have a CT scan, which is expected to be normal. So they want to exclude that to give the pure patient's data is why I think they should have excluded. This is my guess, a reasonable guess, that is all, nothing to prove that. But PRISM trial should have given the answer, and unfortunately slow enrollment, and they had to actually give up on this. But any stroke, in my opinion, we should go ahead and do, because I put the cardiologist in our perspectives there. If a person has come with a myocardial infarction, the cardiologist would not say it is a small myocardial infarction, I will not thrombolize when the patient has come in the correct time. I mean, that is not acceptable to us. And secondly, we all are particularly of the opinion that the smaller the size of the stroke, lesser is the chance of hemorrhage. So we know on one hand, this patient is not going to bleed. On the other hand, we know some neurons are dying and other neurons may die. We don't have any answer at that time. I really do not understand why they should still go on telling that minor strokes, they should not thrombolize. In fact, the risk data, one of the previous data, and the risk showed that patients who had risks and they were not thrombolized rapidly into stroke symptoms, a good majority could not be discharged home in the United States. They had to go for further facilities for this one. So I strongly am a believer of thrombolysis. There is doubt in that case, which I mentioned, case doubt is that one is that the time of onset you take is 4:30 a.m. Am I correct, sir?
Yeah.
And that means 2 hours of stroke. So how did you really pick up the time window perfectly? Because that's a very odd time. 2 o'clock to start a person seeing at anarthria was difficult to pick up really. Was it a wake-up stroke or really it was there? Was that patient, how did you pick up the timing there, sir? There's one doubt which I'm thinking in my mind. And second doubt in that case is the anarthria as such. So we all believe that if a stroke has to happen, anarthria means motor deficit, as you mentioned, should be just adjacent to the motor cortex, the central gyrus. Now, if it is a left central gyrus, adjacent to that, there was a small stroke which left the language intact. I'm sure anarthria could not have been picked up in the late hours of that night. 4 o'clock in the morning, I don't think we would have picked up anarthria because we wouldn't have asked the patient to write. That is the last thing we would be doing in that emergency setting. You could have picked up the anarthria a little later. Probably in the morning, you picked up anarthria. That's my guess in this case. All guess, no proof, because you were there at the site. I was not there. So guessing that anarthria was picked up only later, probably the stroke would have been a little larger. And then the motor deficits improved, or the stroke is highly focal only to that central gyrus, which is having only involvement of the motor fibers which are producing speech, leaving the language, intact, which is, I think, a rare entity. I have not seen such a stroke really. So maybe experts could comment on this. So 2 things. 1, the timing of stroke. Second, the pure anarthria as a presentation.
No, Meenakshi, pure anarthria can happen, Meenakshi. In fact, that is called cortical aphemia. Cortical aphemia just mimics aphasia. And this just happens because of one small artery which gets blocked and the patient cannot speak at all. And you confuse it with aphasia. And the only way you can differentiate it is they can write and they can write. But then you don't usually test that writing and all, but it is possible. And I have personally, in my experience, one patient who was a singer, actually, professional singer, professional folk singer, who had a anarthria, cortical aphemia, and he actually did not recover, boss, and he was not thrombolized. And till this day, he blames us that he could have become all right. He has become better, but not completely. So that is possible, that you can have sometimes just one single artery which can cause just pure anarthria called aphemia, cortical aphemia. That's possible. But the point here is that whether to thrombolize them or not, I would go for a thrombolysis. The chance of bleeding is very, after all, we are only afraid of bleeding, but the chance of bleeding is very less. As opposed to that, if we don't thrombolize, we are guessing, and we are not doing anything. We are just hoping that the nature will take care and it will dissolve and it will not progress. We are just praying to God, but we are not doing anything from our side. But if we have to do anything from our side, then we have to thrombolize. After all, there is a particular clot, presumed clot, which is causing this. We are lysing that clot by doing this thing. And the chances of, even in Pooja Khatri's prison trial, the chance of bleeding was 2%. But we must realize that the trial was not completed. It was an incomplete trial. It had to be, they could not get enough patients. Therefore, it was prematurely terminated. But other than prison trial, which was an incomplete trial, I have to tell you, it was an incomplete trial. But other than that, because I have surveyed this data, if you look at most of the data, they have found that there is a benefit by thrombolizing these minor strokes. So my vote would be for thrombolysis. The chance of, even in stroke mimics, they are now advocating you can thrombolize. The chance of bleeding is very little in these. Of course, you have to look for blood pressure and other things and other confounders which may cause that. That goes without saying. So I would thrombolize the patient, in short. Yeah.
Yes, sir.
Kaul sir, can I ask one thing? See, somebody who has aphasia or anarthria obviously causes profound disability for anybody, especially if not. Say you have a patient who, typically you have mild hemiparesis, and you examine, you see mild facial asymmetry, a little bit of pronator drift, and mild EHL weakness. You put together the NIHS is 3 to 4. The language and speech is okay, barring a slight slurring because of the facial. In that, and if you make the patient walk, he's walking okay. So NIH say 3, this time not much of language and all involved. So into inverted comma considered minor. The disability may be neuronal plasticity may, if we don't thrombolize, may take over and cause full recovery. Like, it happens many times that they recover.
Yeah.
What would be our take in that?
The thing is that in all these situations, we are not sure what it's going to be. He can progress also. After all, we have seen patients who have progressed, who look very minor to begin with. And on second day, when you come for the round, they are having grade 0, right? So now in this situation, why you are not thrombolizing? Mainly because of the fear of bleed. That is the economical thing comes second. Main is the fear of the bleed. So it is a tricky situation, but I think I personally would be biased towards thrombolizing, clearly. Now, the question is, I have to explain to the patient. And I will explain to him that, look, he has got a minor thrombosis, minor deficit. But there is a medicine which I'll give you. It may it can improve you. It can prevent further progression. But there's a risk of the bleed. If he does not take my suggestion, then obviously I can't help it. Then I will not give it. But my bias would be to thrombolize this patient based on the simple logic that there is some clotting happening somewhere in his small vessel. This clotting is happening. Now I'm depending on God and on some natural processes which will dissolve that. But if I thrombolize him, I'm doing something to thrombolize at the cost of a small risk of bleed. So even if a patient comes with a minutest deficit, I would thrombolize. That is my take on it. But I would be very careful in taking the consent, in explaining to patient, and in writing. And most of the times I have been successful in this. But you are completely right that sometimes some patients may resolve on their own also. That's also right. But as a doctor, I would definitely discuss with the patient. And, many times patients have refused thrombolysis and they have become all right. So it's not that they are wrong. But, at the time when patient is with me, he's in a situation where he can deteriorate or he can improve spontaneously. But I would thrombolyze him in order to facilitate that thing. But if he doesn't agree, it doesn't matter. His decision is okay, and he may improve or he may not improve. But as I'm trying to make myself very clear that my bias is towards thrombolysis rather than not towards thrombolysis. Yeah.
There is one more call, sir. Typically, we get a call from resident, sudden hemiparesis, power 1 to 2. By the time in 15 minutes you reach, you see the power has come up to 4. He's not completely normal, say half an hour. But still the NIHS says like 4 or 5. I err on the side of thrombolizing. I say
yes.
What is
the
your
improvement?
Take,
you are completely correct. I also am with you. The improvement should be complete.
Absolutely.
Means there should be 100% power. If there is 90% power, I would still thrombolyze him. Yeah. But let us hear what Meenakshi says. Meenakshi's word is final. Meenakshi, your word is final.
Sir, not at all, sir. Pre-final, semi-final, sir. Sir, we follow your footsteps. We thrombolyze the person whenever, even if they have improved, even if a minor deficit is there, can improve. Sir, can I share one experience here, sir?
Yes.
I think that's one experience I'd like to share with the permission of Dr. Paul, sir. Sir?
Yes.
Hello.
Not there.
Hello. No, I'm there. I'm there. Please tell me.
What's your question? Experience I'll share. In 2009, we did our first preceptorship program. Yeah. Subsequently, we were training people from the periphery for thrombolysis. Yeah. Now, one of the questions that was raised is that why they are not thrombolizing, like myocardial infarction, straight they thrombolyze. Why there's a hesitation for stroke? Now more people are thrombolizing. And one of the reasons they all said, one of the reasons is that in stroke, there is so much of complexity involved. In myocardial infarction, you see a ECG, the line goes up thrombolyzed. That is all, as simple as that. You don't have to ask anything for that. Whereas we have 25 criteria laid. You do an NIHSS, you do a CT, 1/3 stroke, 2/3 this one. So many things we put across and baffle the physicians who are thrombolyzing around. So over a period of 1 year, initially my first preceptorship contained NIHSS and all as one of the 15 minutes format. Subsequently, sir, I've taken away all these NIHSS out because over a period of time we are realizing NIHSS is small, you will think and then you will thrombolyze. NIHSS is big, acute stroke, you will thrombolyze. It doesn't really make difference. NIHSS is big, you will go for mechanical if it is available. Really, is there a utility to teach physicians who are just joining for thrombolysis in the periphery about NIHSS at all? That question is ever lingering in my mind, sir.
No, I think why everybody is afraid of stroke thrombolysis is only one reason. That is the fear of bleeding. And this fear of bleeding, this is ingrained in the management of stroke. This is a known complication. This can happen. I don't think our science has really become so exact that you can completely avoid that. Even in a very well-controlled trial of NINDS, bleeding happened in 6% of the patient. That will happen. Once you have to take this decision, there is a small risk of bleeding. So even when you thrombolyze a minor stroke, there is a 1% chance that patient will bleed. But you have to realize in 99% it will not happen. In 99% it will not happen. Or in 98% it will not happen. So it's always a risk and benefit analysis. So I think this we have to, previously when I used to give consent to take consent from patients, I used to tell them that, look, I'm giving a drug to you. It can cause bleeding and patient can die and all. That would scare the patients. Now, I don't tell all that. I said, look, I am giving this drug. It can help the patient. It may not help the patient. But I don't go to the details of telling it may cause bleed and all that thing, because that suddenly makes us very, very defensive and all that thing. After all, bleeding is a part of the natural course of the stroke. Even without thrombolysis, also bleeding can happen. In fact, petechial hemorrhages is a part of natural disease process. So therefore, I think when you have a minor stroke, thinking that it will resolve on its own is okay. But then you are not doing anything. You are not interfering. You are just hoping. That hope may be realized. That hope may not be realized. So therefore, we will always have two kinds of people, those who would thrombolize and those who would not thrombolize. And both are right in their own way. But I would thrombolize. I would thrombolize in this situation. Maybe sometimes I may take a little diplomatic route of giving little less dose, which I usually do. If it comes to now for tenecteplase, we don't have that problem because tenecteplase dose in India anyway is less than what is recommended in the world. That is this 0.2 milligram. But when it was alteplase, I would tell them just give him 1 vial. That 1 vial would come to a little less dose than
0.6 milligram.
Yeah. No, it would come to 0.6 or 0.7 also sometimes, So, I remember for 10 years, we always used to do these debates. Should I be thrombolized? Should we not thrombolized? Should we? But this is not rocket science. This is not mathematics. This is a simple approximation that some clotting is happening somewhere which is blocking his vessel because of which he's having. And it can progress in next 24 hours. Better to get rid of it. Just thrombolize him. That's it. There's a small risk of bleed, but we have to take that risk. But of course, all this has to be done with, we have to tell patient in his own language. Majority of the time, there will not be any bleed here. Let us be very, very realistic. Bleeds happen when there's an uncontrolled hypertension, when there's a very elderly man, when the risk of when the size of the infarct is very big, when he is beyond the window period, 5 hours, 6 hours. Usually in a patient who is within 3 hours, with a very small infarct and very small, the chances of bleed are not zero, but they are very less.
Sir, one more comment, sir. Sir, just one thing for the viewers here who are listening to this. Recently, I read a book on stroke written by one brilliant neurologist from Salem called Dr. Balamurugan.
I know Balu. I have attended his videos. They're fantastic. Yeah. I am his fan.
Yes, sir. We are all his fans.
What is it? I have borrowed his videos. He has given me his videos also. And what is the name of the book?
He has written a book in Tamil for general public, sir.
What is the name of the book?
Pakkavadam, sir. Stroke only.
Okay.
And it is written in a very jovial manner. But there is one point which can be shared by me for all people who want to thrombolize, the young people who want to thrombolize.
Please do that. Please do that, Meenakshi.
I learned from it. I used it in one of my patients. Very successful, sir. He writes all things in terms of stories only in that book. Brilliant book, sir.
Yeah.
Highly recommendable, award-winning book. There he writes in that, when you ask for a consent, so he gives an example, which I used in one of my patients now. Let us say your house is on fire and the fireman arrives. You tell him, no, you wait. When you go inside, you must get all the money out of the left corner, which I put. And I put jewels on the right corner. I put important documents in the second floor in the middle compartment. And my child is also there. Everything you must get it out. You give me guarantee, then I will allow you to enter my house and go and put the fire down. Will you ever tell that? Obviously, there will be risk. You will be losing something. You will be gaining something. But by putting out the fire is how you are going to gain a lot. This simple example he taught, sir. The next patient itself, when they ask, no, sir, what is the risk? Because everyone has his Google in their hand. The moment I said this example, they said, sir, please go ahead and thrombolize.
Yeah.
It's a very simple example he taught, sir. That book is highly recommendable.
Fantastic. Will it be translated to other languages?
Sir, I do not know, sir. It is written in such a humorous language also. I know whether it be carried. I will definitely tell him. Highly recommendable, sir. For Tamil speaking people, the book.
Yeah, I'm so happy. I know Bala very well. I have borrowed his videos. He's fantastic. Thank you. Yeah.
Sir, my last question, Dr. Ashokan. Sir, Kaul, sir.
Sir, please.
A situation where the patient comes to you with TAAs, multiple TAAs. For example, it's occurring from yesterday, multiple TAAs. Already had 4-5 TAAs. This is the 5th TAA. And he has come within 1 hour of last TAA, where you do MRI and diffusion weighted, everything is normal, and MR stroke protocol doesn't show any arterial occlusion. In such a situation, will you now thrombolize or wait for him to get another TAA, which may be rather the worst TAA?
Dr. Ashokan, you have asked such a important question, which all of us have faced in our life. And, if you go by guidelines, you are not supposed to thrombolize a patient who has no deficit.
Yes.
Because after he recovers from TIA, he has no deficit. But at the same time, he gets another TIA. Then he gets, and the situation is worsened if one of the MRIs shows already some flare hyperintensity. Now, these are typically patients of what is called crescendo TIAs. And they usually happen in a syndrome called capsular warning syndrome. Capsular warning syndrome, in which they can have 50, 60 TIAs. And I have seen these patients. My personal experience is you should thrombolize them. And my personal experience is that thrombolize stops them. If you look in the books, textbooks, they will tell you they will keep on having TIAs, they will keep on having, and finally they will get a stroke, which will be a permanent deficit. If you please today check the books are telling about crescendo TIAs. There will be hundreds of TIAs, but finally they will get a stroke. Now you can break that. And this I'm telling you based on my experience and the experience of my friends and colleagues, which we have seen over the course of time. What happens is that because why this happens, why they are having these crescendo TIAs? Because there is one particular vessel on which a thrombosis formed. Then it's getting dissolved. Then it's again formed. Then it's getting dissolved. Then it's again formed. This thing is happening many times. Once you thrombolize these patients, you dissolve that thrombus. You break that cycle and they will not get a further attack. But only thing is, the problem is with the guidelines. According to guidelines, you are not supposed to thrombolize if the patient is having no deficit at all. So what I do is that I thrombolize these patients. Suppose I know he's having TIA. The moment he gets a next TIA, before he recovers, I thrombolize him so that I'm on the correct side of the guidelines, so that I can write on the case sheet. Because if I thrombolize him once he's totally recovered, then I'm going against the law. So I'm afraid that he should not recover. So before he recovers, we thrombolize him, right? And once it has also happened that once the vial was broken and the patient recovered, but the vial was broken, but I thrombolized him still, and he did not get any attack further. So the take-home message is that in crescendo TIAs, particularly if you are having 3-4 TIAs, Dr. Ashokan, you have said, you can confidently thrombolize him. 99% chances are that you will be able to terminate his attacks. This is not written in books, but this I can tell you based on my experience and experience of my friends like you, because we always consult each other, in the city whenever we have got. And this is the experience of so many of our friends, that you can break that, just give him thrombolize, but preferably thrombolize him not when he has recovered, when he has a deficit. Immediately thrombolize him within 5 minutes. Otherwise, he may again recover. And again, you will have this problem. Yeah. You should know why you are doing a thing. Dr. Padma is a great friend. She's not here right now. But we always used to say, you can break the rules provided you know the rules, provided you know the basis of the rules, right? Guidelines are made for safety, so that there should not be any inadvertent, overzealous use of these things. That's why guidelines are made, for the patient's safety. But once you know the mechanisms and why these things say, you don't have to slavishly follow guidelines. Once you know there's a patient who's having 10 times TIAs, again and again, you want to break that cycle. And thrombolysis is a good way of breaking that cycle.
Yeah. Thank you, sir. Thank you very much. My last doubt, I would like to know from your experience, how frequently we are successful in thrombolizing capsular warning syndromes, because these syndromes are supposed to be due to the perforator vessels, small vessels. Any other
I am actually telling you about that only. Capsular warning, we are quite frequently we are successful. Quite frequently we are successful, provided we have thrombolized in time. Yeah.
Because we have we were not successful in a few cases of capsular warning syndrome. In spite of our doing our thrombolysis, they ended up with a stroke. That's why I'm asking you this.
Well, I mean, that is the standard position. but we were successful. I mean, telling you very frankly, with my hand on my heart, we were successful in breaking this cycle. That's why I thought it was rather, But I think we should, thinking that it's a capsular warning syndrome, therefore I'll not thrombolize it, is not the correct way. The correct way is that in that capsular warning syndrome, during the attack, if you are able to give it, maybe that is that would be the correct thing to do. Yeah,
Yes.
rather than not. Because anyway, your outcome is bad. If you don't do anything, he's going to land with the hemiparesis as per our standard literature. But if you do something, at least there's a chance that you may be able to break that cycle.
I totally agree with you, sir. That's what.
Yeah.
We are going to thrombolize.
Yeah.
But in our small experience, we could not succeed in 1 or 2 cases. That's what.
No, you are Ashokan. You are totally right. That is what is the standard teaching, and you may not succeed, but you are only trying to increase the odds of success. Ashokan, let me tell you one thing. This whole game of thrombolysis is about increasing the chances of success. There is no guarantee in it. Even when we do TPA in a routine patient, there is no guarantee. If you have got you are only increasing up to a certain extent. You cannot guarantee everybody that you are thrombolizing that he will recover. No, you are only trying to increase the chances of success. And same holds true about capsular TIA also. But I would definitely not recommend it to give it at a period when he has no deficit at all. I would like to give it during the period when he has a deficit. At that time, quickly give it to be safer side ourselves also on the side. But tell me one thing. I would like to learn from you. The patients of capsular warning where you thrombolize, did they get any bleed after your TPA?
No bleed.
Yeah. So that is good. That's good. As long as you are not causing any bleed, you are trying your best.
No,
yeah. See, your question, Ashokan, your question is valid, that you are talking about the mechanism, that in the kind of the mechanism which they have in small vessels and while you are giving thrombolysis, how it will go. But I think nobody talks about large vessel, small vessel in thrombolysis. That thing has been sorted out long back, that thrombolysis is recommended for all vessels, whether it's a small vessel or whether it's a large vessel. In fact, in the NINDS trial, maximum benefit was found in lacunar strokes only. And these crescendo TIAs of capsular warning are small vessel lacunes. They're small vessel lacunar TIAs. They're lacunar TIAs in the internal capsule. So that way they should work. I would stick my neck out and I would say you can try your thrombolysis in these patients and hope that your next patient does better.
Thank you, sir. Thank you. Yeah.
Thank you, sir. Thank you, sir. Any other point?
No, sir. There's one question in the chat by Dr. Surendra. What we do if patient has history of left medullary infarct 24 hours back, but in hospital again develop a right medullary infarct with a diffusion fear mismatch?
So you are talking a recurrent stroke within 24 hours, right?
Yes, sir. And it's in medulla, sir.
Medulla.
Usually, a recurrent stroke within 24 hours, going by conventional guidelines, we should not thrombolize again. There's a risk of bleed. The standard guidelines, I would like Meenakshi, Dhananjay, or everybody to comment, but the standard guidelines are that if there's a stroke within past 3 months, then you should not thrombolize again,
Yes.
right? If there's a stroke in the past 3 months, then you should not thrombolize. But there is a little bit of a modification in that, although it has not come in guidelines, but it's accepted in literature that 3 months is too long a period. They say if the stroke is small, like a medullary stroke, then after 3 weeks also, you can thrombolize. That 3 months can be changed to 3 weeks. And I think medullary strokes are small only. But within 24 hours, I would probably not thrombolize them. Again, there may be a risk of bleed. Within 24 hours, again thrombolizing a patient. But I would ask Meenakshi's opinion, what he would think.
It's the same, sir. Because the area, now this patient has got a left medullary infarct, now a right medullary infarct. That means a highly thrombotic zone. However, the left medullary infarct 24 hours would bleed, though it would be benefiting the right medullary infarct. In this patient, I'll put them into the ICU. I'll try to monitor for further progression beyond the medulla. For instance,
Yeah.
there is further progression, consciousness is deteriorating. That means for that stroke, maybe I will give him the chance of mechanical thrombectomy, telling him that there is still a chance of bleeding to the left side. That's what I would do in this patient. If the patient is not progressing, I will leave him like that, wait for him to recover.
Right, Meenakshi. I agree.
Yes, still I think we have to evaluate for basal artery occlusion, and even after 24 hours, if it's a definite basal artery occlusion causing this infarct, I think we should go for mechanical thrombectomy. That can be done in 36 hours if it's a post-circulation stroke.
Yeah, if there's a occlusion, obviously, if there's a occlusion.
Vertebral. There has to be a vertebral occlusion where we can perform a thrombectomy.
Sir, last doubt. Sir, actually, I wanted to ask about carotid disease. Like we had two patients. One patient, he came in window period, we thrombolized him around 6 in the evening. Around 10, left hemiparesis, right MC infarct. By night time, he improved. Almost 90% improvement was there after thrombolysis. But by next day morning, he again developed infarct in the same area. We did a carotid Doppler. In that carotid Doppler, there was a complete 100% stenosis of ICA. So in such cases, sir, and the second case was she came 1 week back, 60-year-old female. She was having multiple TIAs. She did not have a stroke. We didn't thrombolize her, but she was having TIAs. And on doing Doppler, there was again 100% thrombosis of left ICA and around some 70% thrombosis of right ICA. In that patient, because there was no acute stroke as such, we only gave her heparin. But the TIA stopped. There was some resolution of the thrombus. But what can be done in such patient where there is massive, 100% stenosis of carotid arteries?
You see, when you talk about these carotid arteries, you have to talk of this. You always talk about the culprit artery. So you have to say, you don't talk of both arteries. You have to talk of the artery which is symptomatic. So what was happening in your symptomatic artery?
Sir, first patient was a symptomatic side.
So let us discuss both patients separately so that we are not confused. So let's talk about your first patient.
First patient, sir, he had right MC infarct and there was right ICA 100% stenosis and left hemiparesis. He had a reinfarct. I mean, after improvement by next day morning, again, he had full left hemiparesis.
Yeah. So you have to give supportive treatment.
Anirudh, did we document another diffusion weighted abnormality in a separate area?
No, sir. The MRI was done only once after the next day morning.
Sir, Kaul sir, sometimes it may so happen that the deficit can evolve,
Yeah, progression.
Progression of the same stroke. Maybe the thrombus temporarily dissolved and then the thrombosis reoccurred in the same area and the same stroke progressed. If there was no diffusion weighted new abnormalities shown on a repeat MRI, it is possible it was the same.
Yeah.
Irrespective, I would have, if there is a chance up to M2, I would have considered mechanical thrombectomy for the second event if there was a chance for doing so. Obviously, like we earlier said, in 24 hours is a risk.
Yeah. Yeah, I agree with you. But if there's a complete occlusion, and that also he's telling carotid artery occlusion.
Yes, sir, I see.
Yeah.
Internal carotid.
Yeah. I mean, you can try mechanical thrombectomy in that patient if he is within 24 hours. Was he within? Did you notice that second event within 24 hours?
Yes, sir. By next day morning, yes, sir.
And how was the size of the infarct at that time? How was the size of the infarct?
So the MRI was done.
When you did the second MRI, did you do the second MRI?
Sir, there was only a second MRI. There was no first MRI before the first infarct.
And how big was the infarct? Then
Sir, it was not very big. It was not more than 1/3 of MC. Not a very big infarct. Not complete or near total.
Then you are right. You can, if he's within 24 hours, and if you think that the patient has progressed or you're not sure, it may even be a new infarct also, then theoretically speaking or even practically speaking, you can give him the option of the mechanical thrombectomy, provided you have got a mechanical. But that has to be done within 24 hours. So they have to go and they have to try to pull out the block. Yes, sir.
the problem is with 100% ICA occlusion. Our intervention specialists are not very keen to try out negotiating a 100% occlusion, sir.
No, you are completely correct, because even as per the guidelines also, this is 2B recommendation. 2B recommendation means that you may try, it may help or not. The interventionalists are completely divided in this. The aggressive ones go and they will still try. The conservative ones will not touch it. If there's a complete block in the carotid, that is why site is very important. As far as the T junction is concerned, which means at the terminal ICA, their complete occlusion is there. It's an absolute indication for taking out. But when it comes to the extracranial neck artery, half the people will do it, other half will not even touch it. So, but we are trying to think of what is the possibility, what maximum can be done.
Yes.
So if you have got an interventionalist, he may try to suck out that clot which is there. Many of the interventionalists have told me that it turns out to be dissection many times.
Yes.
Dissection many times.
Yes.
Yeah.
Agree, sir. To me, it looks more like total occlusion at its origin. ICA at its origin looks like. Probably in such a cases, thrombosuction and stent retriever, probably they would have gone for stenting. Angioplasty and stenting. So it looks like it's not only thrombus, underlying stenosis, severe stenosis, and this should have occurred at the origin itself, IC origin itself. So probably if you want to go further, thrombosuction, stent retriever, then stenting. Before that, maybe angioplasty, then stenting.
Comment.
There's one thing.
One comment.
Dr. Meenakshi, can I say one?
Please, sir, please.
Yes. There's one thing. If the worsening occurs in a way by which patient redevelops dense hemiplegia, that's a different thing. But if the deficit is fluctuating, I would hype up the blood pressure, maybe increase the MAP up to 100 because IC is totally occluded, the pressure head may be poor, and I might try and increase the MAP to, I've done this in a couple of patients, and that has helped prevent the fluctuation of deficit and stabilize the improvement that I had achieved by my earlier practice.
Correct.
One comment, sir. In this case, it's a difficult case. So the point is, let us look at two options. One, chemical option. Second is mechanical option. The previous trials with chemical options in the form of abciximab, the trial was met with a failure. So the written thing was that as of now, we do not know what to do for a progressive stroke. That is where as of now we still stand. Regarding the mechanical option, you told me that the patient has worsened in his weakness, yet the patient did not develop a large infarct in the brain, you told me. If this is true, I will think of a chronic carotid occlusion with collaterals. And probably a 90% occlusion is now going for 100%. At that point of time, we will ask our radiologists whether they can say how they would rate the plaque morphology, what we are seeing. If they think it is an acute thrombus which is occluding, probably still it is worth a try. Because to navigate the catheter from down across a huge segment of block and reaching there and doing it is nightmarish most of the time. It just doesn't come out at all. It's very difficult to do it. So if we think that it is still negotiable and the patient is still failing, maybe we may have to do it. Otherwise, uniformly, these patients would end up, in our experience, with hemicranectomy rather than anything. This has been our own small experience. Sir could tell us.
No, you are right, Meenakshi. I agree with you.
Sir, Meenakshi, shall I tell you one thing? The thing is, that's what, see, it looks like something like any other thing, acute on chronic. Maybe, as you said, this is a chronic occlusion, but acute has caused this. But only good thing is the core volume is still not very much increased. As the presenter told, core volume is very important. If the core volume is large, under such a situation, you will never think of thrombectomy, mechanical thrombectomy. Since the core volume is not very much large and it's small or what it may be, it's definitely worth trying thrombectomy. And if it is a chronic, this thing, stenosis, etc., stenting. Yeah.
Acute stenting will be quite difficult, sir. Very difficult.
Yeah, that's no. That's what I told you. Balloon angioplasty. First angioplasty, then stenting.
Because immediately it closes, and you place a stent there. The immediate thing they would say, this patient was thrombolized. The next thing they would say is you give a dual antiplatelet. And the day after tomorrow, you say there'll be a large bleed. So we have had problems with our hand when we had done acute stenting, sir. We had a couple of cases, then we discussed also here. Difficult to stent at that time, sir. Difficult.
Yeah, I agree with you, Meenakshi. We had a problem like that. Rather, first pass, you remove something. Second pass, you remove something. Again closes. Third pass closes. See, after fourth pass, we didn't have any other option. And we had to give tirofiban intravascularly. Intra-arterially, and the site of occlusion. Then, of course, we were very lucky we didn't have bleed. Then, lastly, we put in the angioplasty. After tirofiban, no more closure of the vessel. Came out, and after 2 weeks, went for stenting. So, luckily, touch wood, nothing happened to the patient. See, imagine tirofiban, antiplatelets, etc., etc. Of course, luckily we didn't thrombolize because late presenting stroke after 9-10 hours. But with these things, it didn't bleed, and they had very good recovery. That's what I'm telling.
Yes, because the patient is thrombolized, acute stenting will be very difficult, sir, for us. Because to keep that stent intact, will be very difficult.
Yeah, that's what I'm telling you. Not stenting. See, initially go for plasty, balloon angioplasty. After thrombosuction and after stent retrieval, you go for angioplasty. Then wait for 2 weeks or what it may be. Then go for stenting. Yeah, and that's what we have been doing. That's what I told you. Okay. Thank you, sir.
Yeah. I think it's a evolving field, and I completely agree that that all these options are there. Particularly if the infarct is big, then it's better to do plasty alone rather than putting a stent, because then you don't have to give double antiplatelets. But if the infarct is small, then you can even think of doing stenting at that time. So these interventionists do all these things here and there, and I think we need few more years before we can come to definitive conclusion. Until that time, we have to do it case by case basis. Yeah.
Sir, in that second case I was talking about, actually what I wanted to ask was that, sir, when he was saying, Ashokan sir was saying multiple TIAs. If a patient is having multiple TIAs and we are not able to catch the patient during the event, we obviously cannot thrombolize if the patient has no deficit. At the same time, we can't send him home because there are multiple TIAs. Is it okay, or is it advisable to put him on heparin?
Multiple TIAs?
Yes, multiple TIAs. Because this patient, which I told second patient, she had TIAs, but with carotid occlusion. In that patient, because obviously I couldn't thrombolize, I put it on heparin.
No. Did he have a multiple TIAs in the same distribution in which there's a carotid occlusion?
Yes, sir.
And
definitely.
In spite of your double antiplatelets, his TIAs didn't stop.
No, sir. She actually came that she was having since last night. She's had 6 or 7 episodes of TIAs, of facial deviation. So I didn't give her antiplatelet and send her back home because she was having very short period of time multiple TIAs. So that.
See, sir, I'll tell you one thing. As per the guidelines, as far as possible, it's always safer to stick to guidelines. Then you are correct, and
Yes.
you are also safer. So, as per the guidelines for TIAs, these days the ideal treatment, class 1A treatment or 1B treatment is to give double antiplatelets with high dose statins. So, if this patient comes to me today, and I have also learned it over the last 30 years and reading guidelines, but today, if a patient of recurrent TIAs come to me like this, I would load him with clopidogrel 600 mg and ecosprin 325 mg. I will load him and statins 80 mg. This is as per the guidelines. We are not breaking any law for a TIA or a minor stroke. But after another 6 hours, if she continues to have TIA, again, as per the guidelines, you can give him heparin. This is 2B recommendation, that if you have a TIA with the evidence of a block in an artery where you are seeing that there is a clot or a thrombus, you can treat him with heparin. It's not a strong recommendation, but it's a recommendation. So it will be perfectly okay for you to heparinize this patient. But before heparinization, it's better to try whether antiplatelets can help you. And this is being totally within guidelines. I'm not saying anything, from a personal experience-based. It is an evidence-based treatment.
Okay.
Yeah.
Thank you.
So you're okay if you heparinize him. But first try your loading dose of aspirin and clopidogrel. It usually works along with high-dose statin. In fact, the heparin usage has come quite down. In my time, and I mean, when I was young like you, I used to heparinize everybody because I had done a fellowship in US and everybody used to be heparinized, even though they were the people who would say don't heparinize in their books and in their journals, but everybody was heparinized. In fact, Massachusetts General Hospital, MGH stands for Massachusetts General Hospital, but in humor it used to be said MGH stands for must give heparin. So everybody used to be heparinized, and the leader of them was Louis Kaplan. There was a lot of opposition, and I also belong to that. But after double antiplatelets came, the use of heparin has come quite down, because we should face it that heparin has a risk of bleeding also. And then we used to give indiscriminate heparin. So obviously it would not help. So heparin should be used in very selected people, where there's a crescendo TIAs, where you are sure it's because of the clot in this particular artery and you can stop it. In those cases, you can give heparin, and it is now even in guidelines also. The latest guidelines of 2020, if suppose you've got a vertebral artery clot and you're getting recurrent TIAs and you know that you can give heparin. But even in those cases also, first try full dose double antiplatelet. If it fails, then give heparin. That's what I would say. Yeah.
There were two previous trials. So now this guideline sir has mentioned, the two previous trials one was with unfractionated heparin. Second was IV continuous heparin, monitoring the PTINR. Both of them did not show benefit in stopping the TIA. This was previous trial I'm quoting. And the difficulty which sometimes you will face is that once you have heparinized them, if they develop a large stroke in front of you, you will not be able to thrombolize them.
Correct. That's absolutely correct.
Face. So preferable to keep them once they are having TIA. As sir said, if it is capsular warning, go ahead and thrombolize them. Otherwise, keep them under your care. The guideline which I follow, I'll just share here. Earlier, we used to admit these patients in the ICU, and that is catastrophic because it will be missed. The stroke will be missed in the ICU. It's practical point. So always nowadays, I admit to a stroke unit and allow the relatives to be on constant vigil.
That's a brilliant comment which you made every time. And that's a brilliant. I mean, if it was in my hand, I would give you a Nobel Prize. What you have always been telling, that don't put a patient in ICU, your stroke will be missed there. That's brilliant.
So, and then I put the relatives on 12-hour duty. They have to tell me the moment the stroke starts, because in guidelines, if TIA lasts more than 20 minutes, statistically, the chance of this becoming infarct is very high. So 20 minutes, we'll also have time to organize ourselves, everything. That also gives time to respond also. So the moment the stroke starts, instead of us starting the clock, because the relatives have a responsibility, they start the clock and they inform us that this has started. And we time it with them. 20 minutes is guideline for us. Beyond 20 minutes, we know that the incidence of finding an infarction on MRI in diffusion weighted image is very high, that statistical chance is there. Then we go ahead and thrombolize. This is what we have practiced. Sir.
Yeah. Right. Because this is always a question that when a TIA becomes a stroke and when I can thrombolize him. Once you have given heparin to him, then you cannot thrombolize him. But if you have given double antiplatelet, also you can thrombolize him. But only thing is that with one dose of heparin, if it's a low molecular weight heparin and you have given him or even a conventional heparin, if you give him only one dose, and it is kind of one dose becomes a kind of a prophylactic heparin dose. that way you can thrombolize him. But if you have given him more than one dose, then obviously it becomes difficult. So all these patients have to be dealt with, individual basis. But we need a good experience and a good base of knowledge. And based on that, we can take a decision in each case. Each stroke is different, Meenakshi, Each stroke is different. There can be no cookbook approach to this. This is each stroke is that Miller-Fisher didn't say just like that you learn neurology stroke by stroke. Each stroke comes with its own situation and you have to take a decision. But definitely there is no replacement for sound base of knowledge, absolute cutting edge. You have to know what is the latest trial saying, and you have to learn from experience of others, your own experience, and then take a decision in each patient. That is what makes stroke so fascinating. So are we done for the day? I
think so. Shall we stop here, sir?
I think it's 9:40. We're supposed to go till 9.
Yeah.
So you're the boss. You decide.
Yeah, because it was very fascinating discussion. So I was listening. So I think this is the time to stop now. Thank you very much. Thank you, our course director, Dr. Subhash Kaul sir. I thank our moderator, Dr. Ashokan sir. I thank our moderator, Dr. Meenakshi Sundaram sir. And also thank Dr. Shripad Pujari sir for today's very interesting discussion. At the same time, I thank our speaker, Dr. Aniruddha Deshmukh and Dr. Surendra Kosha for their interesting case, which built so much of a discussion. So we'll stop here and we'll catch up again for the next month with 2 new interesting cases and a lot of discussion. Till then, thank you very much and have a nice day.
Thank you. Thank you.
Good night.
Good night. Thank you very much. Sir.
Good night. Namaste. Thank you.
Thank you. Ashokan sir,
thank you,
sir.
Thank you.
Thank you, Dr. Shripad Pujari sir. Thank you, Emcure sir. Bye.
Thank you.
Thank you,
Bye.
Thank you.